very important topic in exam because head and neck, thorax also is very important, abdomen is very important. All these are important topic in the exam. Okay, so is anyone need to start? I just show him the picture, and after that he need to comment on the picture. Anyone? So this is what happened in exam. They show you the picture like this and tell you enumerate, just enumerate. Maybe ask you later some question. دكتورة آية أنت رافعة إيدك. Okay.
تمام.
Okay, you can start. You see the screen, by the way?
Yes.
Oh, again, the picture you have in exam is either from the museum of the Royal College and usually not colored at all. No color at all. Okay, so you can start. You can see A, B, C, so you can start by A, B, C, all this.
A sternocleidomastoid.
Yes.
B trapezius.
Okay.
A, B, C.
C is here. Small muscle.
Posterior belly of omohyoid.
No, but omohyoid, yes. Okay. Okay. D.
D. D.
Okay.
Rhomboi muscle.
لا, not. You can see later, no problem. H.
H is a nerve. It is a nerve.
Okay. G. Nerve come from the back of sternomastoid muscle and
yes, it is a spinal accessory nerve.
H spinal accessory can, but what is G?
Yes. G, it is the great auricular nerve.
Okay, good. A, B, C,
F.
D, F. F is a muscle, may be difficult. Okay, E.
It is FD. It is splenus capitis. حاجة كده. Splenus capitis.
Okay.
E. دي E masseter.
Okay. All right. L
في I. ده L.
L.
L. It is thyroid. L فوق.
Yes.
It is a facial nerve.
Facial in front of parotid. So this is something like artery come from here, piercing the skull. Okay, I show you the same picture, but maybe closer. Okay, so as you mentioned, A is sternocleidomastoid, correct? B is trapezius, is correct. C is omohyoid, correct. D is levator scapulae muscle. E, of course, masseter. F is splenius muscle. Okay. After that, it's the same picture also. We have G is the greater auricular nerve, correct. H is spinal accessory supply both trapezius and the sternocleidomastoid muscle. We have, where is I? This is I is external carotid artery, okay. You mention, okay, which is this artery, corrugated artery in the, over the mandible. You see it, Dr.
Facial artery.
Facial artery. Facial artery, we have two artery corrugated, splenic artery from celiac trunk and facial artery here. Okay, and K, what is K? This one in front of tragus.
Front of tragus.
Usually anesthetist see the pulsation from it. Superficial temporal artery. Superficial temporal artery is important in England because this is artery, the only artery you can take biopsy. In patient of rheumatoid or vasculitis, if you need to take an biopsy from artery, the only artery you can take biopsy is branches of the superficial temporal artery in the scalp. What you looking inside the ear here or side the skull, they cut part of the skull, and this is branch from maxillary or maxillary artery, and they give a branch here. What you expect is this branch? Branch from maxillary artery. Yes. We have external carotid, have two terminal branches.
Middle meningeal artery.
Okay, superficial temporal and the maxillary. Maxillary give middle meningeal artery, which pierces the skull through foramen.
Spinosum.
Spinosum, and of course, this is the cause of the extradural hemorrhage. Okay, so it's easy, it's very common to have this picture in one station. Of course, spinal accessory give trapezius and sternocleidomastoid muscle. Okay, you can stay with us. This is a triangle again, posterior triangle, anterior triangle of the neck, and spinal accessory nerve. Okay, this is the anatomy, what you make tracheostomy. So it is between, this is thyroid cartilage, this cricoid, between cricoid and suprasternal. Usually you make tracheostomy. Okay, still with us, Dr. Aya. Okay, you can see this is also common. We don't ask you about branch of the artery theory. We give you angiogram. So this is angiogram. Of course, this is the skull, and usually we start from down. So, Dr. Aya, what is the branch of internal carotid in the neck?
No branches
Okay, no
on the neck.
branches. So no branches of the neck. So all the branches lower must be from external iliac. You can start from one. This is, of course, common, no common carotid, and of course, 12 is no branches. So it is internal carotid, so the branches come from external carotid. So what is one?
One, it is ascending pharyngeal.
Okay, can. Okay, what is two?
Two, it is lingual.
No, two is the big, is the main artery. It is the common carotid. This is the external carotid.
It is
External carotid itself. What is three?
أنا شفت 3. It is lingual.
Lingual. Okay.
4, it is facial artery.
Okay. 5.
It is maxillary branch.
Maxillary artery. Okay. And for example, 6 is a branch from it. So it is most probably
middle
meningeal. Okay. So what is, for example, this is internal carotid is branches is come. So we have 7, 8, 9. So what is this?
9, it is ophthalmic artery.
The only branch of internal, yes, ophthalmic. And after that, we have
7,
anterior.
it is anterior cerebral artery, and 8, it is middle cerebral artery.
Okay. All right. So if you back again, so one you mentioned it is one is superior thyroid artery. This is 2 is external carotid. Of course, internal carotid have no branch. Number 3 is lingual. You are correct. Number 4 is facial, related to the mandible. This one, I just looking this one, facial. Number 5, correct, maxillary. And the number 6 is middle meningeal artery, one branch which can cause extradural. And again, anterior is the 7, and the posterior and 7, and the 8 is a middle cerebral artery. 9 superficial temporal artery. Back is occipital artery. Very tiny branch, maybe not important, is ascending pharyngeal artery. Of course, 12 is internal carotid artery, and 13 is common carotid artery. I think is okay, but just the lower one is superior thyroid artery. Okay?
تمام.
Easy? Okay. All right. This is area, of course, it is a large picture. This is the nose. This is the parotid. We remove the parotid, and we're looking for A, B. Maybe difficult, but this is in the face. So we have A and B. What it could be?
It is facial artery.
Okay, A facial artery. Okay, and B is look like branch of nerve, tiny nerve.
It is marginal mandibular branch.
Official. Okay, so B is the marginal mandibular official, correct? A is the facial artery corrugated. And you have C here again. What is C? برانش اوف
هو كده
فيشيال،
برانش من الفيشيال. اوكي.
ممكن يبقى temporal او دي temporal branch of facial. Okay, so it is important because some students become in panic when see slide like this, but actually usually you ask about common thing like facial branch of facial nerve or facial artery, and this is area is in front of the mandible, this is the nose. Okay, so again we don't have this in exam, but this is the area. So this is a parotid. This is the facial with 5 branch, temporal, zygomatic, buccal, marginal mandibular, cervical branch to platysma. So all this, and this is the parotid duct. Okay, thank you, Dr. I.
شكرا
Okay,
جدا.
again, a facial nerve, of course, come from bones and medulla or bones and medulla, and extend the skull through stylomastoid foramen. It is important, and have 5 branch, which is temporal, zygomatic, buccal, mandibular, cervical, which supply the muscle of the face. So, is anyone, if I ask you like this, what you expect is the next question? If you are in exam and we show the facial and we discuss the facial, what you expect is the next question? Anyone? It is important in exam to have some expectation.
upper motor neuron lesion و lower motor neuron lesion.
Okay, so it is important they ask you in this way. Okay, so I just come to the blood supply, and after that he ask you what is the difference between upper and lower motor neuron lesion. So what is your answer, doctor? What is the
أنا
difference? Can أنا مش شايف. Is anyone need to answer? Okay, you can answer. We have a lot of questions. So what is the difference?
difference, I ask the patient to elevate his eyebrow. It is
Or close the eye in the same side or bilateral. So if he is able to do that, what is this?
Able to do that, it is lower motor neuron lesion affecting the lower half of the face, of the contralateral side, and if he not able to happen, ipsilateral
lower motor neuron lesion.
Lower motor neuron lesion.
Okay, thank you. Anyone just to need to be asked? Anyone? Any volunteer? Thank you, Dr. Dr. Ahmed Fathi. What you expected the next question? After upper lower motor neuron. Okay, not branches. What is the muscle supply by facial? So what is your answer?
After leaving facial canal, there is a stylomastoid and posterior belief digastric, and in facial canal stapedius, and the muscles of facial expressions. 5 terminal branches. Dr. Shireen, you are muted.
Right, sorry. Any other muscle started by S? You mentioned all muscle of facial expression, stylohyoid and?
Stapedius.
Stapedius and? Posterior belly of?
Posterior of digastric.
Posterior belly of digastric. Okay, so this is what is the exam. So in the exams, you ask it about facial, other muscles, and of course, nerve lesion. So this is what happened in the real exam. Okay. All right. So after that, if you ask about sensory or taste branches come or cross or attach it to the facial, which nerves?
Chorda tympani.
Giving what?
Taste sensation for anterior two-thirds of tongue.
Okay. What is the pain temperature for anterior two-thirds of the tongue?
Lingual nerve, branch of trigeminal.
What is the posterior third of the tongue pain temperature and taste?
Glossopharyngeal.
Okay. Second, you are still with us. The second operation is common in England, not in Egypt, is the carotid endarterectomy. Is done in any patient have a stroke to remove the thrombus. So can you tell me 3 nerves related to in carotid endarterectomy related to the anatomy of carotid artery?
Okay, there is lingual and hypoglossal and margin-mandibular.
No, lingual, hypoglossal, margin-mandibular. You are thinking about submandibular gland. No, okay. We ask you about carotid endarterectomy. Carotid endarterectomy in carotid. Okay, carotid endarterectomy means a structure in carotid sheath which can be hypoglossal up or vagus posterior or sympathetic chain or some tiny branch like greater auricular and superior laryngeal nerve. So what you expect is the next question.
Hypoglossal nerve injury lesion.
Or what
Uh,
happened in hypoglossal nerve injury lesion?
there is deviation of tongue to the damaged side, and there is wasting of tongue muscles.
Of the
Uh,
half of the tongue muscle because they have double innervation. Okay, this is the operation for carotid body tumor or carotid endarterectomy. You can find the hypoglossal in the upper part, so can be easy to injure it. Of course, vagus is posterior. Vagus is big nerve, difficult to injure it. Sympathetic chain is more posterior. Okay, so this is again the carotid sheath, and you can find the structures behind, like vagus behind. This is a vagus, sympathetic chain behind it. It's difficult to be injured, but usually what injured is a hypoglossal, which is related to this area. Okay, so it is important to expect it what happened. We still in carotid triangle. In carotid triangle, of course, we have these branches of hypoglossals can be easy injured. We have branches of vagus. We have carotid body and carotid body tumor, which is not common in many countries, but can be happened in England. Okay. So this is innervation of the tongue. It's very important, very easy, very rapid question. And again, lingual pain temperature, chorda tympani is taste, posterior is glossopharyngeal for pain temperature and taste. All muscle of the tongue supplied by hypoglossal except what, Dr.
Keratoglossus by vagus.
By vagus. Okay, are you sure?
Okay, I'm sure.
Okay, so it is important if the examiner asks you, are you sure, just to say, I'm sure. So we speak about glossopharyngeus. So what is the next question you expected?
Supplies.
Muscle supplied by glossopharyngeal is?
All muscles pharynx.
No, not all muscle. It is only one muscle.
Okay, stylopharyngeus.
Are you sure?
I'm sure.
No other muscle. Yes, no other muscle. No other muscle. Glossopharyngeal give only stylopharyngeus muscle. Okay, all right. So it is important just to be confident from your knowledge. Okay. After that, because this is exam is also include ENT, so still with Dr. Ahmed, if you have epistaxis, from which this bleeding can arise?
From little area.
Okay, what is the name of artery?
There is our sigmoidal artery and the greater sphenoidal, which is more important. Greater sphenoidal.
So anterior posterior sigmoidal artery and sphenopalatine artery. Okay, if you are ENT surgeon, and sometimes ENT use local cautery, chemical cautery. So which one of these artery can be secure? Which one is difficult to secure? If you imagine the nose like this, I show you the nose, this little area. So this is the nose. We have anterior sigmoidal sphenopalatine artery. Which one can be controlled by cautery, by chemical cautery, not cautery like use it in surgery? Which artery?
Sphenopalatine artery.
No, sphenopalatine artery is so posterior, is difficult to reach it. This is the nose is from here. The nose is here. This is the nose. Anterior sigmoidal. Okay, so anterior sigmoidal you can secure by chemical cautery. Something they put it by ENT doctors or surgeon. So how to secure or stop bleeding in sphenopalatine artery? What
ligation.
you expect? No, ligation is difficult. You know the nose is very close, very small area. So suppose in your clinic in the emergency when you are houseman, what if you have a bleeding and send it to ENT surgeon, what he put inside the nose? Anyone have ENT experience?
I think nasal packing.
Nasal packing, the easy, any bleeding, if you don't reach it, so the nasal packing. So the usually, we call it posterior nasal pack or whatever. We don't ask you about technique. So the anterior, posterior can be secured by chemical cautery. Chemical cautery is some medication you can put it, but posterior sphenopalatine is impossible to secure, so we put a nasal packing. Okay, so it is easy, just to know the blood supply cause epistaxis, no much detail. I know that the nose is difficult, but it's okay. All right. So again, Dr. Ahmed, where the parotid duct open?
Opposite upper second molar teeth.
Which muscle? Which muscle they pierced? Started by B. Vaccinator muscle.
Okay.
Okay. What you expected the next
Okay.
question? What is the next question?
Mm,
Nerve supply of vaccinator muscle is
facial nerve.
facial nerve.
Okay.
Facial nerve. Facial nerve. Okay. So it is important to know. Just usually you ask you the question and the question build on it. So it is official again. Okay. So this is the submandibular gland where the duct is open.
At the side of perineum, both sides.
Perineum. Yeah. Usually it is combined with the
Floor.
sublingual nerve. Okay. And the stone is common in submandibular gland in comparison to parotid. Why?
Because secretion of submandibular gland is mixed, serous and mucinous, and there is lingual nerve runs along the duct.
No, lingual nerve have good, yes, but it's not cause the stone. Lingual nerve not cause the stone. The stone because this is anti-gravity and secretion is thick or mucus secretion. Parotid is serous secretion, so it is not is watery, so don't cause this problem. Okay, this is lingual. By the way, have triple relation. If you give anesthesia to lingual nerve, which other part of the body is numb? If you give,
I'm sorry, I didn't hear the question.
okay, if you have a stone, you need to remove it in submandibular duct, gland duct. So you give anesthesia or local anesthesia to lingual nerve. After that, what is your advice to the patient? Why you tell the patient don't eat and drink for 4 hours, 6 hours? Why?
Because lingual nerve is responsible for general sensation for tongue, and patient may not feel any hot or cold food on his tongue.
He can he can bite his tongue, he don't feel it. So it is important. Okay. So again, although it is not common, but it is the salogram because some say it's a salogram and this is a duct. So we don't do it nowadays. By the way, saloscopy is also not common to be practiced. If you have a stone in the duct, you palpate the duct, you open the duct. Okay, salography or saloscope is not common in practice. Maybe later, but not nowadays. Okay, which nerves can be injured during submandibular gland surgery?
Marginomandibular and lingual and hypoglossal.
Okay, of course we know the injury and what happened. If the patient have marginal mandibular branch official, what happened to the face?
Maybe an equal smile and the dropping of saliva and
maybe, or they will be have.
They will be having.
Okay, so it is important if something, are you sure? Sure. If you cut a nerve, so it is dropping of the saliva, dropping of the saliva, dropping of the angle. So this is okay. So nowadays, to avoid this marginal mandibular branch official, what is the optimum site for incision of the submandibular gland removal?
5 centimeter below edge of mandible. Edge of
Okay.
angle.
Okay. So although it is not cosmetic, if you make incision in this area, is not cosmetic. It is appear in the past they make it more cosmetic, but they found if it is make a cosmetic or nice incision and cause dropping of angle of the mouth, so this is more bad attitude, more bad facial look. So they say nowadays it is 4 or 5 centimeter below the angle of the mandible. So although it is clear, ugly or maybe not good incision, but this is to avoid marginal mandibular to be happened. Okay, so Dr. Ahmed, we're still with you. So patient, he have something done in the maxilla, in the one tooth of the maxilla. Like nowadays, they make endo, they make nerve root canal, something like that. So which sinus is related to the upper teeth, especially lateral teeth and molar, premolar? Which sinus is related?
Both maxillary sinuses.
Post maxillary sinus. So this is close relation, so can cause sinusitis, and the reverse can happen. The patient with sinusitis have pain in upper teeth. It is common after traveling by flight. So you can find pain in the teeth. You go to dentist, nothing. It is just the sinusitis cause referred pain to the upper teeth. So it's very important. Okay, so during surgery in the mandible, like you make like anesthesia or something, one of the nerve you can be anesthetized is inferior alveolar nerve. What is the origin of this inferior alveolar nerve?
Trigeminal nerve,
Trigeminal is the grandfather, I think, but is okay. All right.
mandibular branch of trigeminal.
Okay, all right. It is okay. It is important if I ask you something. For example, vertebral artery is arise from aorta. Actually, it's from subclavian. Subclavian can be from aorta. Okay.
Okay.
All right. Skull foramina, the important, very common station is you ask you. Okay, vertebral artery arise from what?
From cervical trunk of
No, not cervical. It's directly from subclavian.
subclavian. Okay.
Direct from first part of subclavian, and the
Okay.
two vertebral artery or vertebral artery joined together, causing what artery? What's the artery called?
Basilar artery.
Basilar artery. So it is cross over which vertebrae? Cervical.
Transverse foramina of lower 6 cervical vertebrae from C6.
It is over 7, and after that go to the
Over seven.
foramina, and enter the skull through foramen
Foramen magnum.
Okay, so it is important because if this anomaly in this circle of Wells, what is the patient presented by?
Perianeurysm mean
Perianeurysm causing what?
subarachnoid hemorrhage.
Subarachnoid hemorrhage. Okay. Nowadays in England, maybe not in your country, if you have perianeurysm diagnosed accidental or diagnosed before presentation, how to stop bleeding in the future?
Maybe angioembolization.
Angio intervention, angio embolization, but not maybe. This is what is done. If discover accidental, you can make angio embolization just to secure this is not happened. Sometimes, usually, this hemorrhage occur in old age, like 40. Our patient have attack of hypertension, so this is congenital anomaly, but presented late. Vertebral artery relation to vertebrae foramen magnum is very important topic in exam, because it is just related and it is interested. Okay. You can see the skull X-ray. Of course, this is not one patient. What is in lemon site? What is this?
Extradural.
The artery cause that is?
Middle meningeal artery.
Arise from?
From maxillary artery.
Arise from? Maxillary artery arise from? External carotid. Okay. This is subdural. So it is venous or arterial?
Venous, from bridging veins.
So it is occurring which is young or old?
In old age.
Why? Usually in old age, because the brain may be atrophy, so they have space, and the little trauma can cause hemorrhage. Okay. All right. So this is the skull also, and this is they show you the branches, so anterior cerebral, posterior, middle cerebrals, all these. Okay, this is relation in cavernous sinus. We have many cranial nerve related to cavernous sinus. Just like what?
Lateral wall, oculomotor, trochlear, ophthalmic, maxillary, branches of trigeminal,
All right.
and medial, abducent, and
all right. So okay, so cavernous sinus thrombosis occur after infection in which area of the body?
In dangerous area of the face.
What is dangerous area of the face?
This area is around the nose and the upper lip. Okay.
All right. So cavernous sinus is important. Also, skull foramina is important, is a lot, but at least, of course, foramen spinosum for middle meningeal artery, it is important to know stylomastoid foramina for facial nerve, facial nerve, cranial nerves, and the others. Okay, it is very important, especially the common like foramen magnum, spinosum, carotid, all this. Of course, in the exam we have a real skull or plastic skull, and this is also the area of foramen ovale, and all this. Superior, if you see the optic canal or the optic foramina, so which artery pass in this optic canal?
Ophthalmic artery.
Arise from
Internal carotid.
Internal carotid, yes. Okay, this is easy. And they have optic nerve. Of course, superior orbital fissures have a lot of nerves and the branch, you need to know. So superior orbital fissure, just remember you have lacrimal, frontal, trochlear, superior division of oculomotor, abducent, nasociliary, and inferior division of oculomotor. Okay. Jugular foramina, they have inferior petrosal, glossopharyngeal, vagus, and the spinal accessory. If you ask you if the patient have vagus injury in the right side, you're looking for uvula. So uvula is deviated to which side?
To the opposite side, left side.
Okay, so left side. Okay. We have posterior injugular foramen sigmoid sinus become internal jugular, meningeal branch of occipital, ascending pharyngeal artery. Foramen ovale in sphenoid bone. We have otic ganglia, mandibular nerve, trigeminal, accessory meningeal artery, lesser petrosal. Of course, you don't need to know all these, just big arteries or big nerves. Again, foramen spinosum, medial meningeal artery, meningeal branch of mandibular, and foramen rotundum maxillary nerve. Of course, this is part of the skull. This is again jugular foramina, superior orbital fissure. This is the base of the skull. Usually, if we bring something like this, we ask you one question about cerebropontine angle between cerebellum and bones of the brain stem. Which nerve in this area, cerebropontine angle?
There is trigeminal and
No, not trigeminal. Too important. And you know, acoustic neuroma. Acoustic neuroma arises from what?
from
We
the
don't ask about branch arise in this area. In cerebropontine angle or acoustic neuroma, they are related to two nerves, abducent or vestibulocochlear and facial. This is a lot of nerve in this area, but this is what is important. Maybe this picture is not clear. Okay, this is the origin of the nerves. Of course, most of the nerve arise from bones, medulla, and the midbrain, just oculomotor, trochlear, cerebellum, olfactory, and optic.
Okay.
Pharyngeal arch is very important. And again, first arch is a muscle of mastication. Second arch is a facial nerve, and it is again is important. Usually facial nerve is a common question because it's related to our practice. Glossopharyngeal, again, stylopharyngeus muscles. The others nerve like vagus and all this. All right. After that, we have a thyroid gland. Suppose I ask you exam, what is the blood supply of the thyroid gland? What you expected to tell me? If you ask you
arterial,
vague question, arterial and
venous and
arterial and
lymphatic.
venous. So if I ask you, no, lymphatic is okay. If you ask you blood supply of the thyroid, so we need to mention it is arterial and venous. What is arterial? We start by arterial. Superior thyroid artery arise from?
Superior thyroid from external carotid.
Inferior thyroid artery?
From thyroid trunk of subclavian.
Subclavian, okay. What is any middle thyroid artery?
There may be thyroid M artery.
No. Not my question. This is any middle thyroid artery or no?
No middle thyroid.
Okay. Forget thyroid edema. Thyroid edema is not common. Okay, this is arterial. So apart from this, we have drainage. So middle from superior thyroid, superior and middle is from?
Drain to internal jugular and inferior to left brachiocephalic vein.
Left brachiocephalic. Okay. All right. The blood supply of the how many parathyroid gland do you have?
There are 4.
4 to 6. Blood supply is from where?
Blood supply, superior thyroid and the middle thyroid vein.
No, it's usually from inferior thyroid. Even the upper is from inferior thyroid. But you can say superior, inferior is accepted, but it's mainly from inferior thyroid. Okay. If you ligate superior thyroid artery, you ligate it far away or near the gland or within the gland?
Far away to avoid injury to
No,
external.
relax, doctor. Far away or within the gland? We speak about superior.
In superior upper pool, near the gland, and inferior
Within
away
the gland. Why? To avoid injury
to
of
avoid injury of external laryngeal branch of external laryngeal nerve.
external laryngeal nerve. Okay, superior branch. Okay, if it injures, what happened?
There is hoarseness of voice.
Not hoarsing. It is loss of high-pitched voice. Like the patient, she can speak, but they don't speak in high tone. So if this patient is singer, they be in trouble.
Okay.
The inferior thyroid artery is ligated
Away from the gland,
to avoid.
recurrent laryngeal nerve.
Okay, in surgery in England, maybe not in your country, how to identify nerves during surgery?
By nerve conduction study or
nerve simulation. Nowadays, we have endotracheal tubes, the built-in sensor also, so they can identify the nerve. Of course, it is between trachea and esophagus laterally, but it is easy, the better, the secure, it's just nerve simulation or nerve conduction. Okay, so this is combined arterial and venous thyroid is very important. Sometimes we ask a student, what is this, looking to the thyroid, and he tell us it is a fascia. What we ask about organ. We don't interested in the fascia and others. So usually the common question is the blood supply, how to ligate, and the relation to the nerve. Okay. This is all as related to head and neck. So as you see, the important topic you need to study or you need to ask is related to the thyroid gland, submandibular, parotid, blood supply to the brain, branches of the carotid, branches of fascial. So this is what is important from surgical point of view, because we speak or we teach you from surgical point of view, not from proper anatomy point of view. So it is clear?
Clear.
All right. Okay. So after that, I think we have either upper limb or lower limb, or you can see thorax. Thorax is very important. Thorax, although it is very, very small branch, but is very important as in exam. It is important before we start in the thorax to know that the site, anatomical site of the valve is different than the site you feel the murmur, because the murmur is radiated. So if we ask you, if we give you X-ray or something and you have artificial valve or metallic valve, so it is anatomical position. If ask you where you feel the mitral valve, like stenosis, murmur, so it is the other place, maybe far away, little reps, 2 reps, it is auscultation position. Okay?
Okay.
All right, so we start by thorax. So I think you can, with us, I just share the screen, or it is shared, I don't know. So I think I share the screen. Okay, so it is again important to know dermatome and dermatome upper limb and thorax. We discuss this later, but it is the anatomy of the thorax is important. The important is the outlet or inlet of the thorax. You have many structure. So is any another doctor need to share, or we still with Dr. Ahmed, I think? Okay, you can continue, doctor. All right. So what is the common cause of the thoracic inlet or outlet disease? What is the common tumor? Something in apex of the lung, what we call it? You know Banco's tumor. Banco's is the name of person. Banco's tumor is the apical. So it is the apical. This is area we called it inlet. Some books called it outlet because it is inlet to some structure, outlet to some structure. So it is okay. All right. Of course, right side is like the left side, except one structure in the left, not in the right. What is this structure?
Brachiocephalic.
Okay, apart from names, the thoracic duct in the left side down. So if the Banco's tumor, if the patient have chylothorax, so it is the left side right side, they have thoracic lymphatic, so it is not so important. All right. Of course, this big artery is easy to notice. This is the relation of trachea and the esophagus, and what is the structure is moving around the arch of aorta here. What it could be?
Recurrent laryngeal nerve. Vagus
Recurrent
recurrent.
from Vegas. Okay, so this is why also if the patient have tumor in this area can have hoarseness of voice. Okay. This is the area of deltopectoral groove, which is important for spinal central line or trauma or injury or center line insertion. Okay, so here we have tiny artery, it can be injured in the axillary clearance or in any trauma in this area. You know what is this name of this artery? Very tiny, not
Thoracoacromial.
important. Thoracoacromial artery. Thoracoacromial in this area, and it can be injured. It is not important. Have 4 branches, have no important except during surgery, can cause bleeding, arterial bleeding, so you can ligate it, so don't worry about this. Okay.
Okay.
This is, of course, the lung. I just ask you how many segments in each lung, not loop. How many segments?
In left 2 and right 3.
No, it is a loop. A segment is a segment. Like liver is 8 segments or something like that.
I have no idea.
Okay, it is equal 10 segment both. In all the book, they have 8 and 10, but now it is 10 in both lungs. Segment is like by angio. It is like now you can remove a segment of the lung. Okay. This is the mediastinum, anterior, posterior, middle mediastinum. Usually what is important is posterior mediastinum because it is contain the esophagus and the branch related to the esophagus like vagus. Anterior mediastinum is containing one gland. What is this gland?
Thymus gland.
In surgery, when we remove the thymus gland, what is the indication? What disease can be cured by removal of thymus gland? Occur in young female, affect the muscle.
Lymphoma, not lymphoma.
Not lymphoma. Lymphoma is easy to remove any lymph node. Myasthenia gravis. So myasthenia gravis is the antibodies against anti-acetylcholine receptor. So you can, one of the option of treatment is removal of thymus gland. Okay. All right. Of course, posterior mediastinum, which is important to us, is contain esophagus, thoracic duct, azygos, vagus, anterior posterior vagus, sympathetic chain, splanchnic nerve. Medial mediastinum, of course, is the heart, pericardium, and the big vessels and azygos, anterior thymus and some lymph node, and superior mediastinum is a lot of big arteries arise from heart, like aorta, superior vena cava, and all these. In general surgery, what operation done by thoracoscope nowadays? Common operation for general surgery done by thoracoscope.
Operation for
thoracoscopic. For what? Not for esophagus. No. For hyperhidrosis, what is the operation?
Sympathetic.
Sympathetic. Which level you cut the sympathetic chain?
T1.
Below T1. Okay, just to avoid. If it make it higher, what happened?
Horner syndrome.
What is Horner syndrome? Meiosis, anhydrosis, and enophthalmos. Okay. This is the content again of the posterior mediastinum, so it's important to know esophagus. In Nissen fundoplication, what you will do? Nissen fundoplication. Laparoscopic Nissen. Okay.
Plication floor esophageal sphincter by stomach.
You mean ramming of the stomach around the esophagus? Okay, but what about the opening in the diaphragm? What you will do?
Opening diaphragm. Narrowing.
Okay. So you make 1 or 2 stitches in the opening which esophagus pass. So the ligated the crus of the diaphragm and the wrapping of the stomach around the esophagus. So this is a Nissen fundoplication or toupee, can be 36 degrees, 360 or 2080, 280. But whatever the technique is just wrapping the stomach around the esophagus to just avoid reflux. So why we'll do this operation? What we are fear from reflux? What is the complication in pathology?
Barrett's esophagitis.
What is
Columbus
Barrett's
metaplasia.
esophagus? Metaplasia.
Columbus metaplasia.
What is metaplasia?
There is a change in cell type, which may be malignant.
It is from stratified squamous epithelia to stratified columnar. Okay? So
Okay.
Barrett's esophagus, and can cause which cancer later? Name of cancer?
From
Barrett's esophagus.
adenocarcinoma.
Okay. All right. This is lung, and it is important to know pleura is come from, it is different, so come from 8, 10, 12. So if you have posterior approach to the kidney or something, you can injure the pleura. If you have any injury in this area, you can have pneumothorax. If the patient have tension pneumothorax, where you put a needle nowadays?
In the left fifth intercostal space, mid-axillary
Okay,
line.
all right. So nowadays we put a needle decompression in the fifth intercostal space. In the past, before 2019, we put in second space mid-clavicular. Nowadays, we change it to be in the fifth intercostal space. This change started from 2019, so just 6 years, and it is appear in the ATLS last edition, Advanced Trauma Life Support 10 edition. Okay, we have a paper about this we can share with you. Of course, this is the muscle of accessory respiratory muscle like serratus, muscles, sternocleidomastoid. So this is occur in severe dyspnea, respiratory distress. Usually, the impression of the lung, you can see the aorta, branches of the aorta, esophagus impression, so it is very important also. Something like this, of course, in the picture is not so clear. Usually in the diagrams is like this. Okay, so this is what is in the museum. You can see the picture. Of course, we tell you the lung, it is a lung. And of course, it is, we're looking for the structure. It is important, it is the left lung, by the way. So it is a left lung. So if it is a left lung, what you expected, so it is related mainly to the heart. Dr. Ahmed, what is expected D? What is D could be?
Descending aorta.
Aorta, okay. So what is H and G? Of course,
H
it is a nerves. Yes.
Oh, H vagus, G phrenic.
G phrenic, okay. What is ABC? Of course, because you mentioned this is aorta, so it is a posterior, this is anterior. So ABC.
A trachea hilum, B pulmonary artery, C pulmonary veins.
Okay, we can see here. So of course, D again, ABCDD is aorta. Of course, this is related to the diaphragm. This is impression of the heart, but we're looking for H is a vagus, and G is phrenic nerve. You mentioned A is the left main bronchus, artery above, and artery is B, and C is a pulmonary vein. So just need, if you're looking, I think I put in the group the get through anatomy. I don't know the student who joined us recently can have access, or I need to upload it again. Get through the anatomy is this picture like this. So in exams, usually you have this picture. So sometimes student become in panic of this picture, but it is not difficult. It is easy. Okay. Okay, so this is what is in the traditional book. Like you can see the aorta, you can see esophagus, you can see bronchus, everything. Okay, so of course this is the heart. Anyone or still with Dr. Ahmed? Anyone expert in the heart? Okay, so I think you can try, Doctor. I think someone raised his hand. It is Aya. Dr. Aya, you are welcome. I just show you the heart. Okay. Dr. Aya, okay. All right. You can see it. So usually I don't like, what is A? A is here. What is A?
the wall of the right atrium.
Okay, B.
C, it is the ascending aorta.
Is arch of aorta. And C.
C, it is brachiocephalic artery.
Yes, A, B, C, D. D.
D, it is descending aorta.
Okay. A, B, C, D, E. Where is E? E is here. Something in the blood supply of the muscle of the heart is
It is anterior interventricular artery.
E, F. Where is F? No F or what? F is here. Yes.
It is right coronary.
Right coronary and E, B, C, D, E, F, G. G is
G, it is the
I check. I don't know. I will check, but you can see H.
H, it is pulmonary. It is pulmonary trunk.
Okay, and what is N?
N, superior vena cava.
Okay, just to show the picture. So R, as you mentioned, is right auricle. B is ascending aorta. You are correct. And C is brachiocephalic. D is the arch of aorta. So sorry. E is left anterior coronary or left coronary, anterior descending coronary or anterior interventricular artery. F is right coronary. And G is a marginal artery. We have the same picture. H is pulmonary trunk. I is very small, is left pulmonary artery. J, it is just the ventricle down. K is left ventricle. Okay. L is the carotid. M subclavian. O is left main bronchus. I don't know how to come. And P is inferior vena cava. Okay. So this is the picture, like right coronary, left coronary, marginal branch. So as you see, it is easy. It is just easy to see all this. Okay. I think some noise come from you, Dr. Aya. Okay, so I think it is just easy to mention that the blood supply. Of course, some structure you don't know, just pass it, but just enumeration. So they usually in exams they give you the paper, or this is usually put in the wall. So it is in the wall, and just say ABC or 1, 2, 3, 4, 5, 6. So just to make it easy. If you don't know anyone, just pass it, and after that he will ask you again, or he give you some clue. Okay, of course we don't have this picture, it's just for enumerations, but it is important to know what you have in exam is something like this. Okay, so don't expect it something different. Okay, this is the back of the heart. The same also you can see something like this, and this is looking for superior vena cava and venous system. Okay. So something like this. So this is a correct, like you found superior vena cava, you found right brachiocephalic, you found the other branches of or drainage of the superior vena cava. So it is easy to find. It is above the arch of aorta. Now they have plastinated sample. It is flesh also, maybe little clear, but it is the same also. Okay, this is the vagus and the coronary. It is important to know phrenic nerve. So phrenic and vagus is important structure. This is also the intercostal and the branches of aorta and intercostal. And this is again the vagus in the neck and the phrenic in the neck. So you can find the vagus is more medial, phrenic is lateral, and after that he joins the heart. And again, this is coronary, right coronary arises from the anterior aortic sinus. One is an important topic you can ask it, development of diaphragm, like septum transversalum, dorsal esophageal mesentery, peripheral from the body, and the pleuroperitoneal membrane. Why it is important? Because we have two congenital hernia, like posterior, which is Bogdalic hernia, and anterior, which is called Morgagni. And of course, we have diaphragmatic hernia or loss of one crus of diaphragm, usually presented in the left, and the stomach is up. So this is the anterior or Morgagni hernia, and this is posterior. Just remember PP, Bogdalic hernia. And of course, hiatus hernia by many types. Opening of diaphragm is very important. So vena cava in the T8, esophagus in T10, and thoracic aorta is in T12. Just remember vena cava is 8 letters, esophagus is 10 or 11 letters, thoracic aorta is 12 letters. Opening the diaphragm is something important. Thyroid embryology, I just added because for long time, of course, thyroid is endoderm. But for long time in our study, we think that the parathyroid is ectoderm and arise from ectoderm and secrete calcitonin. Still secrete calcitonin, but recently in 2015, they found the parafollicular thyroid gland is endoderm in origin, and it is derivatives from the fourth pharyngeal pouch. So now they consider parafollicular cell is the endodermal cell, not ectoderm cell. Still neural crest, it is neural origin, but they have some element of endoderm. We don't ask this question in exam, but we ask you about the parafollicular cell because of what? Which tumor arise from parafollicular cell? Is anyone have an idea? Very common. Anyone need to answer? Okay, Dr. Mustafa. Yes? Yes. Which thyroid cancer? Medullary thyroid carcinoma, and can be part of what?
Main type 2A.
Main type 2B, which is medullary, can 2, main type 2, yes. A or B, no problem. So can be pheochromocytoma, medullary thyroid carcinoma, and parathyroid adenomas. What is the tumor marker of pheochromocytoma, and what is the origin of it? Pheochromocytoma is arise from which structure?
What tumor marker?
Anyone? Tumor marker is? Dr. Aya, you can answer. Anyone?
Tumor marker اللي هو vinyl mandelic acid.
In urine, phenyl mandelic acid in urine or metanephrine in blood, but the easy is phenyl mandelic acid in urine. So, Dr. Aya, what other tumor marker you can find in urine?
Tumor marker 5 higher 5 higher in
5 hydroxyindole acidic acid in carcinoid tumor, which is arise from appendix or ileum. The third one, which is rare, is Benz-Johnson protein, and it is in multiple myeloma. So we have 3 tumor marker in urine. Phenyl mandelic acid in pheochromocytoma can be part of multiple endocrine neoplasm type 2, and 5 HIAA or 5 higher or 5 hydroxyindole acetic acid, the end product of serotonin in the carcinoid tumor, can occur in tip of appendix. And the third one is multiple myeloma. They have Benz-Johnson protein. After that, if we ask you about why you can find thyroglossal cyst, because it is failure of descent, because the thyroid is come from up down, so failure of descent of the thyroid gland from the foramen cecum in the tongue, so can be arrested in between, so can have thyroglossal cyst or lingual or suprahyoid or infrahyoid thyroglossal cyst. This is why in sometimes when we remove thyroglossal cyst, we need to remove part or a small part of hyoid bone. Okay. This is as regard head and neck. So again, in head and neck or in thorax, we speak about the common. So what you expected in exam is the common Common thing is common related. So common related to your surgery, not complicated surgery. So in the thorax, for example, they ask you about the foramina, opening of the diaphragm. They ask you about blood supply of the heart. They ask you about esophagus. This is the thyroid gland also can be combined in the head and the neck and thorax. So it is important question. I just have few about upper limb. I think no much. Okay, I think still we have a time. Okay. Of course, we have 3 stations in the anatomy in the exam, and one of the stations you have a bone. So it is important to know big bone like femur, humerus, carpal bone, just the name of the foot bones. Okay. I think I will try to share again. We don't take a time. Okay, so dermatome and dermatome is important. The important you ask it is thumb and the little toe. So 6, 7, 8. So this area is C6, 7, and 8. Just easy to remember. Okay, so 6 is the thumb, rest of the hand is 7, and the little toe is 8. This is anatomical snuff box. Boundaries of anatomical snuff box is important. Middle is 1, lateral is 2 structure. So the middle is only extensor pollicis longus. The radial part is extensor pollicis brevis, abductor pollicis longus. So medial or ulnar border is 1 tendon, laterally is 2 tendon. Of course, they contain a styloid process of radius, carpal bone, scaphoid, and trapezium, and skin. This is branches of axillary artery is important. Just the first segment 1 branch, second 2 branch, third 3 branch. The important for surgery, not in the anatomy, is thoracoacromion, because have 4 tiny branch can be easy injured during dissection of axilla in lymph node dissection of the cancer breast. This is movement. Usually we ask you the movement of the thumb. It is important to know that in the movement of the thumb, this is adduction, this is abduction. So abduction is perpendicular to adduction. So this is related, so adducted become perpendicular, so it is abduction. So if put like this, so it is adducted, become like this, so it is abducted. So just moving of the hand is easy to be demonstrated in exam. This is carpal bone, of course, either by X-ray or by skeletons, just to know. Usually, we have 2 diseases in the bone, like scaphoid fracture or avascular necrosis of scaphoid and leonate subluxation. If I ask you, if your patient have numbness in the distribution of median nerve due to injury of carpal bone, which bone is affected, the scaphoid or leonate? Anyone have an idea? Leonate. So Dr. Muhammad As-Said. So leonate dislocation is related to median. Scaphoid has just pain. Scaphoid fracture nowadays in some countries or in Europe can be diagnosed by radioactive isotope. So can diagnosis early, no need to wait till become avascular. But it's still a lot of debate about this. Okay, so bone, small bone is important. Scaphoid and leonate is the most important. Okay, so of course, if you ask you in the X-ray, so just remember scaphoid, leonate, trapezicum, bisiform, and after that, hamate, capitate, trapezoid, and trapezium. Okay, so just enumerate from medial to lateral, proximal, and distal. Of course, the scaphoid blood supply is arise distally, and this is explain why scaphoid have avascular necrosis. It is like we have avascular necrosis in the neck of femur and lower tibia, but the common is scaphoid and neck of femur. Innervation of the hand is very important. So ulnar nerve, radial nerve distribution, tip of most of the finger by medial nerve, except the last or little finger and the half of ring finger. So it is important to know innervation also. The same dorsal and ventral. Okay, so this is what happened. So this is cubital fossa area. Is any volunteer, anyone can enumerate? Anyone expert, anyone orthopedic, maybe expert in upper limb? Don't be shy. Okay, Dr. Muhammad. I make it bigger. Okay, you can see. So it started by A. It is muscle called?
I think it's no,
Big muscle.
biceps.
Biceps, of course. Okay, and B is?
B.
We have A,
circular
biceps,
lateral.
B is something lateral, C is something medial, this is the elbow, and of course the superficial is the veins, so easy to enumerate. So just tell me.
Okay, B is pronator teres.
Pronator teres is a small bone. I just I make it bigger, maybe bigger like this. So if you make it bigger, is A is biceps and B is brachioradialis. And okay, so we are back again. So B is biceps and B is A is biceps, B is brachioradialis. What is C? C is a small from the flexor. So what it could be? You mentioned just now, B is pronator
teres. Yes.
teres. Okay, A, B, C, D. Where is D? D is vein, which is?
Medial, it's
No, it is
vein.
lateral. No, it is the lateral, doctor. This is lateral.
Sorry, lateral cephalic
so,
vein.
cephalic vein. Okay, A, B, C, D, E. So E is?
Vein
cephalic,
also.
basilic.
Basilic vein, yes.
Okay, after that, A, B, C, D, E, F is important vein, usually common. It is middle cubital vein.
Middle
okay,
cubital.
so A, B, C, D, E, F, G, G, what is this? Tiny nerve.
J, lateral cutaneous.
Okay, all right. So I just to show to you. So again, A is biceps brachialis muscle, of course. B, brachioradialis muscle. C, small tiny muscle, pronator teres. D is cephalic, and E is medial, is basilic, and between it is medial cubital vein. And what is else? G, I think, but G is a radial artery down. So what is J? J is lateral cutaneous nerve of forearm, tiny nerve. And what is K? K here is medial cutaneous nerve of forearm. So K is a middle, J is lateral cutaneous nerve of forearm. And of course L, where is L? E, B, C, D, L. L is bicipital, biceps tendon. Okay. So this is important just to enumerate. Just remember, we don't ask you about much detail. And this is the structures you can find medial nerve, brachial artery in this area. So it is important if you put cannula or something, just take care to don't cannulate or don't insert it in the medial cubital vein. Not inserted in the brachial artery. You can insert it in medial cubital vein. So this is just the anatomy again. You can see the nerve is here. Is of course the brachial artery, and medial nerve is medial in this area in the cubital fossa, is medial all over the way. And the nerve will not appear because it is behind the middle epicondyle, so it is appear in the back. Ulnar nerve, and if you have lymph node here, so you can have compression on the ulnar nerves. You can see the medial nerve is started laterally, then over the brachial artery, then become medial. But the ulnar nerve in the all his way is in the medial side of the artery. So the ulnar usually all over the course, it is a medial nerve is lateral, then over, then medial. And in the cubital fossa, ulnar nerve disappear because it is behind middle epicondyle. Of course, this is shocking, but it is very common. X-ray, not X-ray sample you found in exam. It is a tendon in the front of the flexor tendon or front of the, it is hand, by the way. So this is a thumb. So we'll give you some detail. Anyone need to share to just have an idea? Anyone can just try. Start it from A. Okay. Can? Okay. You try. I make it bigger.
Okay.
No, I just make it bigger. So what is A?
Flexor carpi radialis.
Flexor carpi. Okay, what is B? B is not common, but it's inserted in palmar aponeurosis. So what is could be?
Palmaris longus.
Barbaris longus. A, B, C. What is C?
Flexor carpi ulnaris.
What is D?
D is not bone.
Is
Maybe
what?
flexor bulges longus.
Okay, we can see letter E.
لا, E here flexor bulges longus.
F.
F, where is F? Okay.
Mm.
Flexor digitorum superficialis.
Okay, what is G?
Thinner muscles.
Thinner muscle. Okay, what is J? G and
J
I.
hypothenor.
And I.
Part of hypothenor muscles.
What is H?
H.
Okay, so we can come closer just to make it bigger. Or okay, so A, flexor carpi radialis. B is easy. If you follow up, it is inserted in the palmaris aponeurosis or palmar aponeurosis, so it is palmaris longus. C is flexor carpi ulnaris, and D is flexor
bulges longus.
pollicis longus. Okay, we still here. So E, A, B, C, D, E, brachioradialis. F, flexor digitorum superficialis. F is here. If you come to the thenar muscle, so it is G is adductor pollicis brevis, and H is flexor pollicis brevis. So abductor and
Flexor.
flexor. So abductor pollicis brevis, flexor pollicis brevis. Of course, J is adductor digiti minimi, and I flexor digiti minimi. Okay, maybe difficult, but it's okay. What other is L? Where is L? L. I don't see L. Yeah, L is here, is a tendon. Yes, flexor digitorum profunda of the little finger is the L. It is upper here. So up, and M is here, is the flexor digitorum superficialis. So superficialis, flexor digitorum, and deep of the tip or distal is this one, which is flexor digitorum superficialis. Okay.
Okay.
So I just, because it is a debate, so the thenar, so we have abductor pollicis brevis, flexor pollicis brevis, and in the little finger, flexor digiti, abductor digiti minimi. Abductor digiti minimi is down, and the flexor and the eye is flexor digiti minimi. Okay. Maybe difficult to need. Of course, the brachial plexus is easy to know the brachial plexus and with the origin of the root values, not in much detail. What is from medial posterior lateral cord? Lateral give, of course, lateral pectoral, musculocutaneous. Musculocutaneous gives only three muscle, BBC, so biceps, brachialis, and coracobrachialis. Just remember the TV channel. After that, median nerve. Median nerve supply peroneal superficial flexor muscle, pronator teres, flexor carpi radialis, flexor digitorum profunda, and palmaris longus may be not present. Median nerve supply, motor supply to lateral lumbricals, bonus, abductor pollicis, flexor pollicis brevis, and continuous innervation of the palmar skin and lateral lateral 3.5 digit. Anterior interosseous give flexor pollicis longus, digitorum profunda, pronator quadratus. We don't ask much detail. Ulnar nerve, it is important in ulnar nerve. If we ask you about interossei, it is supply all interossei and the 2, 3rd, and 4th lumbricals. So whatever question asked about interossei muscle, the nerve supply is ulnar nerve for all. First and second lumbrical is innervated by medial nerve, medial nerve, medial 2/3, medial 2 lumbricals by ulnar nerve, the other by medial nerve. Okay. What is important is ulnar paradox or ulnar nerve injury, claw hand, and it has become worse if this is affected in the wrist, not in the elbow. So at the wrist, the can found is more severe, which is partial claw hand. In the elbow, you can have weakness and loss of adduction and inability to adduct the thumb. So ulnar nerve injury is very important. Radial nerve of the posterior and supply triceps and conius brachioradialis, extensor carpi radialis longus, give axillary nerve to deltoid teres minor, upper and lower subscapular and thoracodorsal nerve. Posterior interosseous give extensor muscle like extensor carpi radialis, extensor digitorum, extensor digiti minimi, carpi annaris, abductor, extensor pollicis brevis longus, extensor indicis. This is a bone. So bone is easy, just a scapula, muscle attached to the scapula is not common because it have no surgical importance. Of course, muscle attaches. Anyone just enumerate or give chance for this red one? Anyone? Okay, so you can start. I become bigger. So this is, of course, medial and lateral. We have GIH. So what is this muscle? Major.
G, it will be, yes, lady between 2 majors. The groove will be the distal dorsal.
Yes.
Lateral lip, it will be H. It will be pectoralis major. And G will be teres major.
Okay, what is K? Attached to what?
Again,
What is K?
K,
for?
deltoid. Deltoid tuberosity. Deltoid tuberosity.
Okay. All right. So I just make it. So of course this is the anatomy, but what we're looking for is J is teres major, pectoralis major H. So 2 majors in between latissimus dorsi, and K is deltoid muscle. Nerve supply of the deltoid. Nerve supply of deltoid is axillary. Axillary nerve. Yes, from posterior cord. Okay, so it is important to know that. Okay, all right. So just easy. Lower limb. Lower limb, what is important to us is just to know the between anterior superior iliac spine and the pubic tubercle. So it is midpoint when you palpate the deep ring of the inguinal canal, and mid-inguinal point between anterior superior iliac spine and symphysis pubis, and you feel the pulsation of the femoral artery. Again, dermatome, and it is important to know that little toe is S1 and big toe is L4. Very important. Dermatome, myotome is everything. Okay. So this is the same also. Okay. It is important to remember that if you look into the hand and have loss of sensation in this web space only, it is radial nerve. In the lower limb, if they have the only this space, is deep peroneal nerve. Okay, so as you see here in the picture, of course, you can find the big toe is the branches of saphenous nerve, and this is why nowadays in the removal of varicose veins, we don't do stripping below the knee, because you can injure the saphenous nerve and loss of sensation in the area related to the big toe, but the web between the big toe and the second is the deep peroneal nerve, and again lateral area of the foot is bisural nerve, which is the branches of terminal branch of common peroneal nerves. So innervation of the hand and foot is very important. Of course, this is the femoral canal, and this is important in femoral hernia. And the common question, if the patient have femoral hernia, the middle border is what? Anyone? Lacunar ligament. Okay. And the lateral border? Femoral vein. Oh, so what is the function? What is the function of the femoral canal?
Content of lymph blockade, and it's cave occupying big space for expanding of femoral vein.
Okay, so usually the canal is just for expansion of the vein. Okay, so it's easy. This is the canal again. It's important to know the anatomy of the canal. Okay, so anyone, of course, this is the back of the thigh, and this is the big muscle, which is the landmark here, which is what?
Piriform.
Piriformis.
Piriformis.
Okay, Dr. Aya, so A is piriformis. So what is B? Small muscle.
B obturator internus.
No, we can.
Gemelli.
Okay, A, B, C. What is C? What is D?
D C obturator internus. D inferior gemelli.
G.
G
Quadratus.
quadratus.
Okay. H is
sciatic nerve.
sciatic nerve. A, B, C, D, E, H. After H, J, K. What is this?
G.
M.
M superior gluteal nerve.
A nerve or artery? We can check.
It's
All right.
Artery.
Okay. L.
Inferior gluteal
Okay.
vein.
I come it closer. So again, A is piriform muscle, B superior gemellus, and C obturator internus, inferior is D, and J is quadratus femoris, correct, and of course H is sciatic nerve. So we have another picture. So H is sciatic nerve. I, where is I? I is pudendal nerve. J is nerve is superior, then inferior gluteal nerve, and M is superior gluteal artery. Okay. What you expected if we bring this picture to you? What is suppose the next question? If we speak about the back of the thigh, so what is the next question come to you?
Surface anatomy of sciatic.
Not important. What else? Usually we ask you about
difference of distribution of sciatic.
Say again.
Differences of distribution of sciatic.
No, it is not much important. The important is ask about Trendelenburg test, and this is test because the superior gluteal and innervation. So we ask you something like that. Trendelenburg, all this. Okay. Okay, just a minute. Okay, so it is supplied to superior gluteal nerve, supply to muscle gluteus medius, gluteus minimus, and gluteus medius and the minimus are the abductor, and it is important in this test. Okay, so it is important test in orthopedic. Of course, this is anatomy by colored. We don't use this picture in exam, but it is Trendelenburg. And what is Trendelenburg? If the patient is normally stand in one leg, the other leg, if it's normal, the pelvis is become up due to contraction of the gluteus medius and the minimus, which is supplied by superior gluteal nerve L5, S1, and 2. But if the patient have something in his leg, so the left leg is dropped down, what we called it positive Trendelenburg sign. So it's very important, very common. Again, this is important area, femoral triangle. So Dr. Aya or anyone started by A. Where is A? A is?
It is abductor longus muscle.
What is B?
Sartorius.
Sartorius muscle, yes. By the way, it is femoral triangle is formed by the medial border of the sartorius And again, the medial, not the lateral border of the adductor, because one of the muscles, the adductor, is straight like this. So one like this and one like this. So it is like this. So both are medial border. It is very strange, but you can check in anatomy. You can find both are medial border. So sartorius is a medial border, and again adductor is a medial border because it is perpendicular. So A, B, C. What is C? Maybe difficult. Maybe is inguinal ligament or something. A, B, C, D. What is D? What is E? What is F? What is F, by the way?
If it is the femoral vein.
No, F. I think it is the lymph node. I check. Okay, E.
It is femoral artery, common
Okay.
femoral artery.
What is J or G?
J, it is a great saphenous vein.
Okay, so if it is great saphenous vein, I just bring the second picture just to see. If G is a great saphenous or long saphenous, and if you are correct, F is the femoral vein. Okay, so F is the femoral vein. So the great saphenous joins the femoral vein and saphenofemoral junction. So what is E?
Femoral artery.
Femoral artery. Okay. What is H here? Is the muscle.
Gracilis.
What is K?
It's, it is
Tensor.
tensor fasciolata.
Okay. So again, A is adductor longus and it is a middle border. B is sartorius muscle. C is the inguinal ligament. A, B, C, D is the femoral nerve. E is the artery. F is the vein, and this is long saphenous or greater saphenous join it. H is gracilis muscle. I is rectus femoris. J is vastus lateralis. K is tensor fasciolata. L is vastus medialis. It's very common, very important structure. I just need you to adapt it or to use for the uncolored picture. Okay, so again, popliteal fossa. So I have femoral triangle important, popliteal fossa is important. In popliteal fossa, Dr. A again, what is A?
Popliteus fossa. A, it is Dr. Long. It is
Okay, the
biceps
easy way
femoris,
to
biceps.
remember, if this is E, is the common peroneal. So the common peroneal is lateral or medial?
Common peroneal lateral.
Lateral. So this is the medial border. So A is, okay, so what is J? Superficial structure in popliteal fossa. Is?
J, it is tibial nerve.
Yes, tibial nerve. Okay, and F?
It is common peroneal nerve.
Common peroneal. So this is the lateral. Okay, I just bring it again. So A is biceps femoris. So A, it is biceps femoris.
Is
And
seminoperinosus.
And B is gastrocnemius, C is gastrocnemius. And E is the semitendinosa muscle. It is not a nerve, sorry. And F is common peroneal, so it is a lateral. And again, G is a superficial structure, which is tibial nerve. We don't see popliteal. Popliteal is deep, more anterior, so it is more deep. Okay, it's very important to know so femoral triangle, popliteal fossa, and again structure around. This is the colored picture, so it's easy. This is cut section in the thigh, not in the thigh, in the lower, because we have two bone, tibia and fibula. Okay, and again, this is anterior, this is posterior. So again, Dr. Aya, of course, just to make it easy. So what is the muscle in the back?
Muscle in the back.
Of the back of the leg, so gastrocnemius, soleus, and the anterior. I just may be difficult, so I just enumerated. So A is tibia, of course. B is fibula. So C is soleus muscle. D is gastrocnemius. E may be not present is plantaris tendon or plantaris muscle tendon. After that, F is the interosseous membrane between tibia and fibula. After F, we have G is in the back here is flexor hallucis longus. H, it is posterior, so it is tibialis posterior. I, flexor digitorum longus. J, it is anterior, so this is tibialis anterior, this is tibialis posterior. L is the artery or anterior tibial vessels. M in the back, where is M? M is in the back, so artery of the back is peroneal artery. N here is the posterior tibial artery. Of course, superficial vein laterally, not laterally, medially is long saphenous, and laterally or down here or the back short saphenous. So of course it is difficult, but at least enumerate the tibia and fibula and tibialis anterior, tibialis posterior, and the muscle of the back, which is gastrocnemius, soleus, and the plantaris is present. Okay. Again, this picture is also in Get Through Anatomy. I send it to you. Soft copies already have soft copy for it. If you don't have, just tell me. I send it to the group. I about to finish. So saphenous nerve run with the long saphenous vein, and this is why we don't do stripping below knee. Shural is in the back, and shural is with short saphenous vein. So nowadays, ligation or operation done for veins is done for just above knee. After that, we make multiple avulsion technique. Okay. The common and the important, of course, this is the femur. It is easy to enumerate it, but the important is the fracture neck femur because of vascular necrosis, and you need to distribute. So usually you ask about the blood supply of the head of femur. So the blood supply of the head of femur, if you are young, it is through ligament teres. If you are old, through reticulum blood supply, and easy in the subcapital or superficial. So you have a vascular necrosis of this. So if you ask you about iliacus or iliopsoas tendon, so anyone where is the iliopsoas tendon is inserted?
Lesser trochanter.
Trochanter. What is the nerve supply of iliacus? What is the nerve supply of the psoas muscle? Iliacus supply by
Femoral nerve.
femoral nerve, and is the only branch above the inguinal ligament, and psoas major supply by L1 and 2.
L1, 2, 3.
Okay, so two muscle inserted together, lesser trochanter, one from femoral, one from L1 and 2. So it's important. Of course, all the nerves we know is lateral, except one nerve is medial. I think is obturator is medial, and femoral between the two muscles. Of course, again, this is important. ABC. Anyone? Dr. Aya, what you expected this? What is the tendons attached, muscle attached to ABC?
اللي هو سيريوس اللي هو
SGS. SGS. So we have three muscle. So we have sartorius, gracilis, semitendinosa. So why you ask this? Because each muscle have different nerve supply. It is like a styloid process. So sartorius by femoral, gracilis by obturator, semitendinosa by sciatica. So back again. Okay. So again, SGS, sartorius, gracilis, semitendinosa. Three muscle. And the three muscles have different nerve supply again, femoral, obturator, sciatica. Okay, of course, this is difficult. This is the area is around, we sometimes bring it, but just remember it is easy. So the easy way is just remember, of course, this is, he asked about the tendons arrangement. So if you see it started from E, so it is anterior middle meniscus, anterior horn. So E is anterior horn of middle meniscus. Okay. I is here. So it is here and here. So this is anterior horn, posterior horn, middle meniscus. Okay. F is the cruciate ligament. This one. anterior cruciate ligament. Posterior cruciate ligament is J, this one. So this is anterior, this posterior cruciate ligament. Okay, H lateral meniscus, posterior horn. J is the middle meniscus. So just remember that E and I is the anterior horn, posterior horn of middle meniscus is like this. And F anterior cruciate and J is the posterior cruciate. Okay, it's not common to come, but it's just in case. So in the posterior compartment of the leg, we have superficial part, 3 muscle, gastrocnemius, soleus plantaris. Deep part, we have flexor, hallucis digitorum, flexor digitorum longus, and tibialis posterior, and popliteus muscle. I about to finish, so don't be worried. So this is position of patient during surgery, and one of the complication of patient position, you can compress of the common peroneal nerve, and it can cause drop of the foot, so foot drop. So it's very important. Structure around the ankle is very common to come, and they come in picture. I think I don't have a picture. Is come in picture. So they ask you just to remember the tendon, or any way to remember the tendon behind the medial malleus, in front of medial malleus. What is important to know also is the eversion and the inversion. So usually we ask you the movement. We have two movements. To have flexion, plantar flexion, dorsiflexion, it is through the ankle. But eversion and inversion through which joint?
Subtalar joint.
Subtalar, good. So it is important to know this movement. It's important to know this test. What is this test? Is Thompson test. It is used for what? Not for DVT. Okay, tendo-Achilles rupture. So you put the patient sitting or sleeping. You punch calf muscles. You can find indicate it is not plantar, not movement. So it is tendo-Achilles rupture. So Thompson test. Okay. This is just again is the muscle attached to the greater trochanter. Not important, but all right. If you see here, this is the semitendinosa. This is the area is muscle attached to the greater trochanter. It's important to know this muscle and the nerve supply. Okay. So back again. So the anatomy is easy. Just to put in your mind, what we ask you is the common related to surgery. If you are in head and neck, thyroid, submandibular, carotid artery branch, aneurysm, and subarachnoid hemorrhage. If you ask about thorax, so just remember thymus gland, blood supply of the heart, and relation of esophagus and the foramina of the diaphragm. If you ask about upper limb, apart from bone, so just innervation, nerve injury, cubital fossa, and the name of the muscle in the front and the name of muscle here. In the lower limb, femoral triangle, popliteal fossa, structure around the ankle. Thompson test for tension, for rupture tendo-Achilles, muscle or structure around piriform muscle, popliteal fossa structures, and put in your mind, we see the patient from back, so it is superficial and deep. Just last question. So anyone can just tell me what is Thompson test, because it's very important in both orthopedic and anatomy. What is Thompson test? If you bunch the muscle of the calf muscle, what happened to the leg? If you have tendo-Achilles rupture?
If have rupture, it will be passive.
It will be what?
Negative.
Negative. What mean by negative? It is have no plantar
Will be
flexion.
no plantar flexion.
No plantar flexion. Okay. So why it is common in some country like the Republic of Ireland, not common in your country? You know, the people, what is called river dances, these people who dance by make movement in the leg like this, like have special shoes and drop in the theater. It is like the people who dance it by shoes, like make a noise by shoes and dancing in the leg. We called it river dance. So this is common to in some countries. They have injury of the tendo Achilles. It is like in ballet dancer and all this. Okay. So inshallah, next we start pathology next Thursday midnight. After that, we change the time because after Ramadan we stop at the time of Eid. So but next Thursday we still working. Is Thursday is Eid or not yet? Okay. Okay. So
معلش يا دكتور شيرين